Hello? Hello?
Hi.
Yeah. It's Gail Stern.
I don't know who that is. Jillian asked me to join this, and this is the first time I'm doing it, so I don't know who anyone is really.
Okay. I was just hoping somebody else was here.
Oh yeah.
Okay. I'm the administrator for psychiatry.
Oh, okay.
All right now. Hello, can you guys hear us?
Now we can.
Oh, good. Okay, let's start that over again then. So welcome to the 12th of our 12 series of the Project ECHO from Neighborhood Health Centers. We're really glad to see you here. We'll talk a little bit later about when we're planning to start the cycle over again, but welcome to the end of cycle number 1. Woo! And I want you to go ahead and introduce yourself. Let's start with Megan. If you can unmute and introduce.
Hi, I'm Meg. I'm an LPC, and I've worked primarily with substance abuse since I've gotten out of grad school. So that's pretty much it. I work with adolescents too. It was part of the program that I was working at.
Oh, great. Feel free to chime in today while we talk about teenagers.
Okay.
Welcome.
Thanks.
Mary Beth.
Thanks for having me.
Hi, I'm Mary Beth Kohler. I am the clinical case manager with the Connections program at LVPG OBGYN. We work with pregnant women with substance use disorder.
Welcome, Mary Beth. Great to have you back. And also feel free to chime in when we talk about pregnant women today.
I'll do my best.
Yamalisa.
Hi, everyone. This is Yamalisa Taveras from Counseling Solutions of the Lehigh Valley. I'm here as a drug and alcohol counselor.
Always a pleasure. David.
David Zimmerman, Community Health, Lehigh Valley Hospital, and I had 7 trying years counseling adolescents with White Deer Run.
Wonderful. We'll enjoy hearing your point of view in our very short version. Beth Caroli. I don't know if you have sound. It looks like you're not muted. If you don't have sound, go ahead and put some, do a chat, and we'll read it out for you. Gail.
Yes, it's Gail Stern. I'm the administrator for psychiatry. And thank you for the invite.
So glad you're here, Gail. Amy.
Hi, I'm Amy Smith. I'm a medical educator in the Department of Education at Lehigh Valley Health Network and work with the select medical students in the curriculum.
Wonderful to have you back, Amy. Kay Dilch. We're going to unmute you. Can you introduce yourself?
Kathy Diltz, Northampton County Drug and Alcohol.
Kathy, nice to have you back. I don't know if we want to try one more time with Beth. We unmuted you.
Beth Caroli from Quality at Lehigh Valley
Oh,
Hospital.
great. Great to have you here. All right, let's switch to the folks in the room here. You first, Heather.
Hi, I'm Heather Deal. I'm a care manager for the COE at Neighborhood Health Center and a counselor at White Deer Run Outpatient. Hi, I'm Jasmine Rizar. I'm a registered nurse at Neighborhood Health Centers Lehigh Valley. I coordinate MIT and ECHO.
Awesome. Jillian Beecham. I'm an emergency physician, medical toxicologist, and addiction specialist at Lehigh Valley Health Network.
And I'm Abby Letcher, and I'm a family doctor at Neighborhood Health Centers and in the LVHN Family Medicine Department, and your ECHO director. And really excited that we're here at this moment. And we have Andrea here also, who's helping to mute and unmute and make sure that the computers all stay together. Thank you. And I don't know if we have our little script thing.
All right. Hello, everyone, and welcome to today's ECHO Clinic. Before getting started with we just did our introduction. So we'd like to share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your Zoom screen. Audio participants, please dial *6 to mute and *6 to unmute. Prior to speaking during this clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot see you speaking. Thank you.
Okay, thank you. And today we're going to try and cover 3 of our special populations. We'll talk a little bit about adolescents, and we've got some great expertise out in the Zoomosphere, pregnant women, and older adults. And hopefully Lynn Wilson will be able to join us a little bit later on so that she can give her piece about the older adults. But if not, I'm ready to pinch hit. So we'll go through them. I'd like to keep this interactive, so feel free to plot something in the chat or just bust on in by unmuting yourself and piping up at any point, okay? No financial disclosures go along with this. For those of you who are new to Zoom, new to the ECHO, we're using slides that were prepared primarily for HRSA-funded ECHO that ran in 2016 and 17. So that's who those first 2 lovely people are, and Lynn is our geriatric specialist in family medicine. So teens and the brain. We know that teens are their own special species that we love and adore and offer their own challenges. When it comes to substance use disorders and adolescent brain development, I think it's a particularly interesting moment in addiction medicine, thinking about addiction as a developmental disorder, and adolescence as being a time when kids are particularly susceptible to developing a substance use disorder or other kinds of addictions like behavioral addictions. This may be because the brain is still rapidly developing throughout adolescence and goes from back to front, and it's that front area, all that prefrontal cortex that's involved in executive functioning, impulse control, judgment, making decisions, and planning ahead. That doesn't come till quite a bit later for a lot of teenagers, making them hard to understand if you're an adult, but that's part of the joy. All adolescents are doing things that are taking risks, trying new things, looking for novelty. Their brains are primed to do that, so this is what they're supposed to do at their developmental stage, figuring out who they are, who they want to be, and this risk-taking allows them to figure out how to survive new situations. It's part of their development into an adult. So that's normal behavior, but some of the risk-taking that they may get involved in, such as using substances, can put them at quite a lot of risk for injury, including unsafe sexual activity, and sometimes developing a substance use disorder. One of the interesting things is that when we look at some of the large population studies, the opioid use and actually a lot of substance use has decreased in adolescents over the last 5 years. This slide was prepared in 2016, but still the trend is going downward from the last data that I could find in 2018, including much less access of prescription medications. Teenagers have reported, instead of 54% saying that it was easy to get prescription medicine that wasn't prescribed to them back in 2010, it's down to about 30% who say that now. So overall, less opioid use among teenagers, but that doesn't mean no opioid use among teenagers. Little aside, lots of vaping among teenagers. That's the topic right now in the adolescents. But for those who do use opioids and have developed opioid use disorders, there's a much lower chance that a teenager is going to receive treatment compared to older adults. We can speculate as to what that's all about. Some of it may have to do with stigma. Some of it has to do with perceptions of addiction as being a disease of older people and not of adolescents. These are things that need to get challenged as we think about what are some of the precursors of the things that put people at risk for addiction. And also it has to do with regulations. A lot of places aren't set up to treat people under 18. We had a case earlier in the year where that was one of the big barriers, that had a 17-and-a-half-year-old who was needing treatment and appropriate for treatment and yet couldn't find a home that could coordinate the care that that person needed. So we'll run into a lot of those sort of barriers, and we can talk about that. And while we think about the teenagers as the under 18, it's this 18 to 25-year-old group, which is still developing that prefrontal cortex and still laying down pathways in their reward systems and so on, that this group is particularly susceptible to fatal overdoses and have some barriers to access to treatment as well. Anybody want to add anything at this point? So an important thing to mention, and I'm sure everybody in the room knows about that, there is no age limit for consent for substance use disorder treatment in Pennsylvania. Any person can say they want treatment, and that's enough. You don't need parental consent for a 16-year-old. You don't need parental consent for a 14-year-old. You don't need parental consent for a 12-year-old. There's no age limit. The slides will be available on our website, and the link on the bottom goes through the consent laws in Pennsylvania in a nice, concise way. It gets confusing because for mental health and for reproductive health care, the age is 14 to 18, but for substance use disorder, there's no limit for age and treatment. It's ideal, and we'll look at this in a second, to have the parents or caregivers involved in care, and there's some evidence that there's better outcomes when families are involved. That's true for any age group, but particularly for teenagers. So we'd love to have parents in the loop, have parents consenting for treatment, have consent signed to be able to share treatment decisions and information with families, but sometimes that's not possible. So teens can access treatment without parental consent, just essential to know, and that also has come up as confusing for some of the teenagers that show up on our doorsteps. It's important to make sure that teenagers know that the care they will receive is confidential, and all of us should be doing everything we can to maintain that confidentiality, but they need to know that there are some limits to that, including because they are minors, if there's risk for significant harm to the patient, that teenager, or to others, then we're mandatory reporters, so we have to tell. So trying to say we're confidential and there are limits. And in many offices, if you're not used to dealing with these issues, there are other common errors or barriers that might threaten the confidentiality, such as insurance notification. If we put a diagnosis on there and it shows up on the bill that goes to the home and somebody reads it, then all of a sudden you've blown their cover. Co-pays for medication might be a barrier. And then transportation is a barrier for people too. So that's some of the ways that, some of the things that become difficult when it's a teenager consenting for themselves without wanting their family involved. Anything else anybody wants to add about that? Come on. So medication treatment for adolescents. 2016, the American Academy of Pediatrics did release a policy statement that said that we should be treating teenagers with medication-assisted treatment when appropriate. That changed the atmosphere, I think, in many clinical settings, and has opened it up so that even though many of the regulations for treatment programs limit to 18, that clinically, those of us who prescribe medication-assisted treatment, we are not limited in that way. Family involvement, we touched on this lightly, that family involvement is a goal, but if we're practicing harm reduction and motivational interviewing and meeting people where they are, then sometimes that's not where the teenager is just yet. However, it's useful to let the teenagers know that often people do better when they do have their families involved, that the families may need support because it's a very difficult family set of issues. And if the families are involved, we can offer them support as well. That may help the teenager more than get in their way. And one important piece for us working with families is to make sure that all families have access to overdose education and naloxone rescue kits. So our checklist for treating adolescents, make sure you're talking about confidentiality, but discussing what are the limits to confidentiality, sign releases to be able to talk to parents and caregivers if possible, get the family involved as much as you can, including naloxone rescue kits, offer MAT treat, and make sure that you use the same sort of protocols to make sure that you've talked about how to use the medication and where to store it, make a plan for contraception, including screening for sexually transmitted infections, and engage teenagers with prosocial activities, connections with peers who are sober, et cetera, et cetera. Okay, that actually is kind of it for the teenagers. Lots of references here, and we'll make those available, like I said before, and some resources in general. I don't know whether Meg or David, you guys want to talk a little bit about what are some of the resources that are available locally for teenagers? Yeah, Melissa might want to chime in on that.
It's Meg. I didn't have a ton of experience with teenagers who were using opioids. There's a lot of pot and vaping and getting in trouble at school for that. So I don't know. I don't really have any good resources as far as opioid use goes.
As far as adolescents, for us over at Mars, we have basically the #1 functioning adolescent program. And again, because there's no age limit, we do treat any age as long as they're seeking treatment. If insurance is a barrier, the county will cover them, and they will not need their parental consent to do that, of course. So they receive IOP, they receive OP, and if they need to be set up with a higher level of care, that can happen as well. And we are in Bethlehem.
Thanks, Yamalisa. Do you have anything yet to share about the Colby Academy and the school?
As of right now, they are planning their grand opening. It's going to be, I believe, the second week in August. And I think it only, I was in a meeting, they were there. It's gonna have 95 openings. Basically, they're gonna enroll 95 students into the program, and it's not treatment, and that's something that they want to make clear. It is not treatment, but they will be set up with treatment if needed, and they will follow a regular high school curriculum. They'll have sports, they'll have activities, but they'll also have groups available to provide support.
Great. It's a very interesting new program that will be available to our teens. David, did you want to add anything?
I just comments about the recovery community. It's always been kind of difficult for adolescents. Right now, at least in Allentown, I don't know if there are a whole lot of meetings available where adolescents can go, even some meetings that are young people meetings. Adolescents go when there are a lot of older people there. And I'm not as familiar with Narcotics Anonymous, but that comes with a lot of caution and trepidation as well, that, kids have to be very careful about who they fall in with when they do attend recovery meetings, and it requires a lot of support and follow-up for them.
Thank you. That's an interesting set of points of how to navigate. Hopefully having a recovery high school may help with building some community and maybe some creative thinking about additional supports that help teenagers, whether it's opiate use disorders or other addictions.
Yeah, there was one facility, I forget the name of it. I don't know if they're still in Emmaus, but they would have a teen program, and they also did have a lot of activities. I think that was a big part of their whole business plan, was to provide additional activities for the kids.
Great. So if anybody runs across any additional resources, feel free to email them to Star or to me, and we'll post them for the group. All right, ready for women in pregnancy for our
Can I ask one
whirlwind tour? Yes.
About adolescents? Does anyone have thoughts on how we can, what the barriers are to doing MAT in adolescents? I think the biggest one is that it's FDA approved for age 16 and older, right? But even so, everywhere that I've looked, where I do MAT in the network and at Pyramid, we can't do MAT in anyone under the age of 18. Why? How do you think we can overcome? What's the concern? Do you think it's a liability risk because of the FDA label, or what? Because AAP says we should be doing it. I feel like that's a pretty good recommendation, right? Pretty solid. I would be comfortable prescribing someone under the age of 18. And may or may not have done that.
Right?
But I just wonder what the barriers are.
Yeah, and I don't know, and I think, Melissa, I want to have a conversation about this with you later. I think that most of it is that the programs that are offering MAT, for the most part, are licensed drug and alcohol programs, and they're licensed for 18 and above. I don't know what exactly with Mars or with the programs, Dave, that you were talking about in Emmaus, whether it's a different licensing or whatever, but that might be a piece of it. And the rest of it, I think, is just plain fear. I know we faced that with our own agency when we were thinking, well, if we're the only ones that do, then are we going to see everybody, and how many people is that? I think it's really a community issue for us to come together and say, how are we going to take care of our teens and make a solution?
Yep.
All right, let's head to pregnant women. And we do have more resources in our community for pregnant women. So if we first just look at gender and opioid use disorder and think about opioid use disorder among women, that the overdose deaths increased more rapidly among women than among men. So this is scary. I think in the past, people thought about heroin addiction as being a problem of men and men in the city. Then as this sort of new wave came about, still the face of this has been mostly men, but men from the suburbs or from rural communities who more often are not men of color. And we don't really see or think about the women, but the overdose deaths are increasing more rapidly among women. Let me say it again. And when we look at the initiates of prescription opioid misuse among women, that was higher in 2015 when they had this last data available. So more prescription use. And while there's still more male than female adults who use heroin, heroin is increasing twice as fast among women than men. So this is what it looks like when we're at the early point of a shift in the epidemiology in an epidemic, and we're going to continue to see more and more problems with women. So now they're saying 50% of new heroin initiates are women. So that disparity that we saw that might have been protected for women in the past is gone, and we can think about reasons for that. But now we have a new set of issues. We look at pregnancy and opioid use disorders. Nearly 50% of pregnant substance use disorder treatment admissions are for opioids. So we may be seeing women who are coming in admitted and have a diagnosis of substance use disorder. Some of them may be meth or cocaine or marijuana or alcohol. Half of them in pregnancy are opioids. That's stunning. And now the overdose mortality has surpassed hemorrhage, preeclampsia, and sepsis as the cause of pregnancy-associated death. And the Lehigh Valley is not immune to this condition. If we look at it all together, gender, pregnancy, and opioid use disorders, 86% of
Someone's not muted.
I think Yamalisa's on there twice. 86% of pregnant women with opioid use disorders report that their pregnancy was unintended, whereas in the general population, it's less than half. So here's the big opportunity to prevent pregnancies, that women with opioid use disorders are at high risk of an unintended pregnancy. Pregnancy can be a powerful catalyst for women to engage in treatment. Generally, women want to do well for their babies, best that they can. During pregnancy, adolescents report the highest illicit substance use in the month prior to getting pregnant. So if we keep pulling at our layers of risk, teenage women using opioids, high risk for pregnancy and high risk for overdose. And then there's a trend toward reducing use over gestation. And Mary Beth may want to talk about this a little bit, that people do pretty well during their pregnancy. But the question is, then what? It used to be that what people talked about was medically assisted withdrawal in pregnancy, detoxing women. They get a diagnosis of pregnancy, send them to detox. This is not recommended in pregnancy by ASAM, the World Health Organization, the American College of Obstetrics and Gynecology. We do not recommend detoxing women. Withdrawal management is inferior in its ineffectiveness compared to MAT. That's either methadone or buprenorphine, and increases the risk of relapse without any fetal or maternal benefit. That's a pretty damning statement, so let's not do this. There's an increased rate of relapse and associated overdose death following detox, and increased access to treatment has been associated with a reduction in heroin overdose deaths. So we see it both directions. Another study, which in the non-slideshow version, all the references are in the notes for this section. They quote a study that showed that women on methadone maintenance treatment had increased treatment retention, better number of obstetrical visits attended, and more likely to have an in-hospital as opposed to out in the field delivery. Those are good things. We like that. The treatment options in pregnancy, this is a busy slide, but if we look at the left, the methadone is the standard of care. It's got a couple of issues with the once-a-day dosing that may not actually be optimal for women later on in their pregnancy. Couple of contraindications, and maybe has some lower birth weights compared to buprenorphine. Buprenorphine is on the rise in pregnancy. Our Connections Clinic has been offering buprenorphine now for over a year for pregnant women. And you can see, while it's still a pregnancy category C, which means we don't have a ton of data, we actually do have a fair amount of data. And compared to methadone, lower preterm deliveries, better birth weights, larger head circumferences, the babies grow well. We like that. You can adjust your dosing, and the treatment retention for pregnant women may be more in the favor of buprenorphine over methadone. And I'd love to hear Mary Beth tell us a little bit about what that looks like in the Connections Clinic. Is she still there? Yeah, Mary Beth, can you add anything right now about what it looks like for the women who start on buprenorphine at the Connections Clinic?
Can you guys hear me?
Yes.
Okay. Yeah, so we utilize the Subutex induction with our moms in our Connections program if they are not already coming to us on methadone already. We will also work with those pregnant women as well. But what we are seeing with our moms that are on the Subutex versus methadone is that after a baby is born, baby generally has been requiring less observation time with either in pediatric unit or needing to go to the NICU. And we're also seeing lower scoring when it comes to NAS. And also less medication intervention needed for our moms with our babies who have been on the Subutex versus the methadone. Just the length of stay seems to be a little bit longer with our moms who have been on methadone throughout their pregnancy versus Subutex.
Great, and that would be backed up by this study that I brought up here called the Mother Study that was from 2010, and it compared methadone and buprenorphine and exactly those results.
Yeah.
Thank you. Perfect.
Good timing, right?
Yeah, so I think what's important to look at is that the MAT of any kind helps mothers, helps them with their recovery. It helps prevent overdose death. It helps prevent bad outcomes from the pregnancy, and it also helps the baby. So we see better neonatal outcomes for the moms who are treated with MAT, and buprenorphine may have the edge here over methadone. But again, if someone's comfortable in their methadone program, that's the place for them. Naltrexone, this is the Vivitrol. There's starting to be some data. I didn't look to see if there's anything that's come out in the last year or so. I don't know if you guys have. But what about naltrexone in pregnancy? In one way, we would think, well, that involves detox, and that's not recommended, so we're not going there. On the other hand, we don't have much data about what that looks like. There are no human long-term outcome studies. Those are not studies that are going to get approved at this point. But there are some published case studies, and it doesn't seem to have any bad effect on the developing pregnancy. And the point here is that for some patients, particularly those who are already stable on naltrexone, it's worth keeping them on the naltrexone throughout their pregnancy, as long as they understand that we don't really have any information about the effects one way or the other. This last bullet point on here I thought was really interesting, that a study, and I don't remember the details, that surveyed women who were in treatment about what are their interests and how would they like to be treated. There's a lot of maternal interest in being treated with naltrexone to be able to completely avoid any sequelae or effects of the neonatal abstinence syndrome. I think they really want something that that protects their baby in that way. But right now, this is not that option. It just reminds us that, one, there's still lots of stigma about the methadone and the buprenorphine, and two, they have a good point that it would be really lovely to be able to get through pregnancy safely without exposing your baby to the possibility of neonatal abstinence syndrome. Intrapartum and postpartum, I condensed a bunch of these slides so that we would get through it a little bit faster, but the big point is continue your MAT at the same dose through labor and postpartum care. So no taking it away, should be able to do fine at the same dose and decrease it afterwards. And the main issue that women are concerned about is what are we going to do about pain? The best way forward is to try and make a plan ahead of time. We know that with all kinds of birth plans, you know, the unexpected happens, but to be able to think through together, the clinician and the patient, about whether they want to avoid opioids as much as possible, whether they don't, and how they want to approach sort of stepwise the decision making for that. The more of that can be worked out ahead of time, the better. And I'll say that the major point here is that women can have and must really have adequate pain control during and after delivery of their baby, and that we can achieve that using NSAIDs and non-opioid pain medications, using opioid medications when they're necessary, and that when they are necessary, women on MAT are going to need higher doses of opioids. So helping to educate the staff who will be receiving those requests from patients for pain, that the higher doses actually are legit and not someone just asking and feeding their addiction and relapsing right in front of you, that that's not what's happening, that we're helping to manage their pain. Breastfeeding. Methadone and buprenorphine are safe for breastfeeding. Raise our hands to the roof a little bit for that one. The maternal opioid intake does not really get transmitted into breast milk. It's good for moms. It increases their oxytocin levels, helps to lower stress, increase maternal-infant bonding, and both of those lower the risk of relapse. So it's great for moms. It's great for babies. We already talked, actually we didn't, but a big topic out there is that the breastfeeding and the skin-to-skin contact is very effective treatment for some of the lower symptoms of neonatal abstinence syndrome. So should be a standard of care and leads to shorter hospital stays. So it's good for moms, good for babies. Our only exception is for HIV positive women. They should not be breastfeeding in this country. But hepatitis C, you can breastfeed as long as there are no cracks on the nipple. So just working with moms to understand that breastfeeding is healthy for them, and as long as there are no cracks or bleeding or pain, that they're fine. And if they have cracks and bleeding and pain, they can actually pump and dump until those are resolved, and then go back to breastfeeding. And again, this is the American Academy of Pediatrics, ACOG, Academy of Breastfeeding Medicine. Everybody agrees that breastfeeding is the way to go as long as women are not HIV positive. Contraception, we already looked before at how many women who have an opioid use disorder are at risk for an unintended pregnancy and repeating the cycle all over again. Let's talk about contraception. So everybody should be, all women, period, should be offered reliable contraception postpartum. Should talk about it during prenatal care with a good plan before you get to the hospital. A lot of contraception can be initiated right at postpartum. And we should be talking about long-acting reversible contraception like IUDs or the next one on for all women. Relapse prevention. Now this is where the heartbreak comes, right, Mary Beth? There's a high rate of relapse after birth. Women tend to do pretty well while they're pregnant, engage in treatment pretty well, and then they have their babies, and life gets really complicated. So, number one, continue the MAT. 2, Narcan for everybody with a good safety plan, train the family members. Watch for postpartum depression. Talk about support for recovery. This is where our certified recovery specialists can be so important. NA and AA, things that are flexible around a woman's schedule, but can help them have a way to talk about what's really challenging and what are the threats to their recovery in real time in the moment. Also talk about support for parenting. You're doing 2 big things at the same time that are full of chaos and confusion. So having a new baby, you know, what's the support for parenting? I think one of our biggest supports out there is the Nurse Family Partnership, and they've been participating in a lot of our echoes. I'm really excited about that. That's home visiting programs with nurses. ACHIP is a similar program that has some community health workers that can support moms with newborns. Safe Start is a program locally that is specifically for babies with neonatal abstinence syndrome. That's a Head Start program for those infants and helps the moms and the babies navigate all of that. So we want to be looking at support for recovery and support for parenting. We need to think as a community about decreasing barriers to care. So many of these barriers of attendance requirements. If you're a newborn mom, that's pretty rough. Can you bring your baby to treatment, et cetera, et cetera. So we're thinking about some creative solutions to that, but still a lot of work to do in our region as a whole.
Particularly when we say that you should breastfeed your baby every 2 to 3 hours, and then we expect you to come to
for a 4-hour counseling session with
no baby.
Yeah. So there are lots of. I think for any person who's experiencing caring for a newborn, your world is turned inside out and upside down, and to try and figure out how do I take care of my baby, how do I take care of myself, and how do I really pay attention to my recovery. That's a big haul even without going to a treatment program. So what are our safety nets? So stay tuned here. Keep your fingers crossed, everybody. We have a SAMHSA grant out that we're still waiting to hear if we're funded for the 4th trimester collaborative to address all of these issues. And even if we're not funded, the group has been getting together, and stay tuned. We're going to do some fun stuff. Mary Beth, what else do you want to add?
I mean, you covered a lot of what I had sort of in my little note for this. One of the other things that we do tend to see and utilize, so when a woman is pregnant, she does have a high frequency of visits. So within our Connections program, we even see that as a really good time to utilize motivational interviewing techniques if needed, so we can get some additional buy-in for sobriety, treatment, long-term recovery. And one of the ways we do that is we attempt to co-locate as many services as possible. So at her visit, she'll be meeting with one of our providers. I'm also available, so if there's anything that needs to be done regarding connection to other community services, I am an LPC by trade, just not an LPC with LCPG. So I can offer some support in that area. But we also have a collaboration with Pyramid Healthcare, and we have a certified recovery specialist that comes to these appointments as well. We do find that the more we can turn this into sort of a one-stop shop for our patients, the better it is and the higher retention for their engagement within this is. It's really difficult for these moms because of those barriers to treatment, those barriers just getting to their appointments, as you mentioned before. So we do try to do that. Obviously, there is a lot of really high secondary motivation because of the pregnancy and because of the baby. And as you mentioned, we do see a higher risk after baby has already been delivered. So to sort of combat that, we recently hired a community outreach liaison for our Connections program as well. So she's someone that if we do have people who are kind of lost to follow up in their postpartum period, can go out and connect with them. Some of the other things we do see are comorbidities with hepatitis and also mental health. So knowing that we have to treat the patient as a whole, not just this is a pregnant woman or this is a woman with addiction, it's this is a woman and we treat her, period. And the only other thing that I would add is just the fear that comes with our moms, even now being on MAT with the new change to the laws in Pennsylvania regarding the plan of safe care, and knowing that any infant born impacted by a substance would be needed to call into a childline referral, and kind of getting our moms to see that as an additional support resource versus something as a punitive measure. So we've been struggling with that and just trying to get our moms to understand that they're not here to take your children away. They're here to provide additional support for these babies if needed. Those are the only things that I would add.
Thank you, Mary Beth. All right, we had a couple of more people join, so I want to have us go around the room this way for the 3 introductions, and then I'll turn it over to Lynn.
Hi, I'm Chris. I'm a community nurse with Neighborhood Health Centers.
I'm Naomi. I am a Center of Excellence Care Manager for Neighborhood Health Centers.
And I am Lynn Wilson, family physician and geriatrician with Lehigh Valley Health Network.
Before we move on, can I question?
Yes.
Regarding pregnancy in women, within the incarceration section of all of this, at one point I know methadone was used in incarceration. But I also know that through Northampton and Lehigh counties, they had at one point pulled out having women who are pregnant and using methadone. And I know that was a concern within the community. Do you know anything on that, if they're now continuing to use methadone within the incarceration?
That's a great question. Kathy, do you know anything from your Northampton point of view? You're muted. Oh, wait. Kathy, can you *6 to unmute if you have anything you want to add about that? Incarcerated women who are pregnant.
If not, Abby, I can share. It's Mary Beth.
Sure, yeah.
So we have several women currently who are detained at both Lehigh County and Northampton County. And if they're already on MAT, the jails are continuing them on the MAT for their pregnancy. I will say that we did have a mom who was detained postpartum who was on MAT, and she was detoxed off of it because she was no longer pregnant. Don't know if that helps.
That rings true.
Yeah.
Thanks, Mary Beth. Yet another point of advocacy for us in the future. Yeah. All right. Over to you, Lynn.
So we're going to talk about the next growing population of addicts, which is actually older adults. Likely have always had substance use disorders, but in general, substance use disorders are thought to be that of younger people. And so most of the advocates of screening for substance use disorders have actually, most of them stopped, 60, 65, sometimes 70. And there had not been a lot of research about substance use disorders in older adults in general. New research now from SAMHSA and some of the other groups are showing that substance use disorders are on the rise among older adults in the United States. There's at least 8 million older Americans, so ages 65 and over, who have either a substance use or a mental health condition. And part of that rise has been in thanks to the baby boomers now reaching that magical 65 number. So we see a very different lifestyle and attitudes of the baby boomer generation rather than or compared to the silent generation or the great generation who preceded them. And geriatrics as a whole has really had to kind of change the way that we have approached older adults because of the significant difference in lifestyles and attitudes. Prior generations really were all about kind of, doctor, tell me what to do, tell me what medicines to take or what things I need to do. Baby boomer generations in general are really looking more for a partner in their care. They want to make their own decisions. They don't want to change their lifestyles drastically, those kinds of things. The other piece is that we've realized dealing with stressful life events can lead to risky behaviors. So similar to that which we see in adolescents, as people are having a significant stressful event in their life, oftentimes they will turn to a substance. And in older adults, these can include things like retirement, particularly older men who had a career as their identity, find a loss of self when they retire. They don't know what to do anymore. They don't know who they are. They don't know how they're contributing. And so, you know, the classic case is the prior functional alcoholic who went to work 5 days a week, no longer has a job, and now can stay home and drink all day. So we're seeing some of that with retirement. Loss of a spouse can be a very significant event, particularly for people who have been married for 60+ years. The loss of your life partner is very significant and traumatic, but also development of a chronic disease. So for some patients, being told that you have cancer or that you have a chronic debilitating condition like ALS leads you down a path of sort of self-deprivation and making risky, bad decisions. And so this is not exclusive to older adults, but it's definitely something that we are seeing now in the older adult population. The other piece of it we have to kind of take responsibility for as physicians, and that is opiate prescriptions for chronic pain have been steadily increasing since the 1990s. For many older adults, opiates were the only thing that worked. They weren't able to take anti-inflammatory medicines or NSAIDs that we use in younger patients, and for many of them, Tylenol, was not enough. And so we have increased the number of opiate prescriptions that we've been giving patients for their chronic pain, and as a result have increased opiate use disorders. Again, we have under-identified and under-treated older adults in primary care for opiate use disorders specifically. Mostly because a lot of the identification of problem patients comes from younger people, not from patients who do what we ask and take the medicines as prescribed and call every month for their refill and, kind of sign on to the contract. But what they are actually doing at home with those medicines, you don't really know. Appropriate treatment for older adults with substance use disorder really mirrors what we do for younger patients, so psychosocial counseling, pharmacologic management. However, it is complicated both by chronic health disorders or chronic health conditions, polypharmacy, so taking more than 5 medications at a time, and both of these things both increase and complicate the adverse effects of substance use as well as MAT. So I have heard doctors say that they don't want to give people MAT because they're on too many medicines already, or they're afraid of the interactions of the medications together. The other piece is that little is actually known about treatment outcomes among older adults. In general, our treatment programs really look at the average 40-year-old male, as Abby described, are, quote, typical addicts. The other thing is that problematic drug use had been incorrectly assumed to end as patients age. So as people got older, we just assumed that they either stopped misusing their medicines or got on the straight and narrow because they wanted to live. The other piece is that I have heard many people say that there are no such thing as old addicts because they die. You either die or you go into recovery. And that's just not true. So the third piece I will say is that you have to define an age limit for what you consider older. I have heard all kinds of ages from 50 to 65 or 70, depending on what you're reading. So it's important to realize what you're viewing as an older adult. Addiction and healthcare services have not really anticipated or prepared for an increased demand by this group. And I will get to kind of the problems with some of our locations in a couple of slides. But the other thing to recognize is medication misuse in this group. So we tend to think of substance use disorders as patients buying heroin and shooting up in the streets of Kingston. But recognizing that medication misuse is also a very common form of substance use disorder in older adults, using prescriptions that are prescribed to them, but for purposes that they're not intended for, or using medications to treat conditions other than those intended. So 1 out of every 5 ER visits involving a prescription medication misuse or abuse among older adults were actually made by somebody aged over 70. The medications, the top medicine that was involved in that medication misuse or abuse was pain reliever, particularly opiates, followed by anti-inflammatories and Tylenol overdoses. The second were medications for anxiety or insomnia, most of our benzodiazepines. And third were antidepressants at a very low rate of about 8%. So what happens to these people? About half of them are actually treated in the ER and released back home to continue their same medication misuse or abuse, with maybe a red flag to the primary doctor or prescribing physician. About 37.5 were admitted to the hospital. Most of them were not referred out for any sort of treatment or screened for a substance use disorder. And then my last slide is really talking about the coverage. So there's no specific coverage for substance abuse treatment under Medicare. The program may pay for medically necessary and reasonable services to treat addiction and abuse disorders if physicians basically write to them declaring the need, and Medicare agrees with them. They may also cover some partial hospitalization program if the doctor certifies a need for 20 or more hours of therapeutic services per week. However, partial hospitalization programs are generally covered by Part B insurance. Part B insurance for patients who have straight Medicare means that they have a 20% copay on all of the services that are rendered, including counseling. And so for many of the patients, that's unaffordable. Not all of our inpatient facilities will accept Medicare or managed Medicare plans. Many of the facilities will decline patients who have significant or poorly controlled comorbidities like diabetes or hypertension. And if you need an assistive device, yes, dialysis, or if you need an assistive device such as a cane, a walker, or a wheelchair to get around, you cannot go to an inpatient facility because it's a liability and a risk. And so those are the significant barriers that I have had personally in trying to get my older adult patients, and even some of my younger patients who have Medicare only as their coverage, into treatment. Interested to hear what other people in the area have had. The last point that I have is that on the patients that I have gotten into treatment, many of them will come back and they'll say, this isn't for me. And similar to the adolescents saying that they go and everybody's old, my patients go and they tell me everybody there is young. They have nothing in common with these people because they are in their 30s, 40s, and for many of them, it is a huge generational difference in their thoughts about addiction, their approaches to their life stressors, those kinds of things. And rather than seeing the similarities, they focus significantly on the differences. Most of the agencies that I have experience with have programs for adolescents and for pregnant women, but nothing specifically for older adults.
Lots to think about. Jillian, did you want to say anything about what you guys see in the ER in terms of older adults and toxicology?
Yeah, I mean, in the ER and in the inpatient setting, it is profoundly challenging to get people, older adults, to treatment. So it's in some cases, at least for outpatient treatment, sometimes the county will step in and help out. But it's a huge challenge. It's almost like Medicare doesn't think an older adult should have treatment. Yeah, like it doesn't exist.
Yes.
So yeah, it's a tremendous barrier. And all the things you mentioned, so we have a ton of patients inpatient. Primarily, I would say actually alcohol use disorder is a big issue. Placement is literally impossible. Whether we're looking for a SNF for a medical issue, going to a SNF with substance use disorder is a no-go, and going to a substance use disorder treatment facility with any kind of medical comorbidity is a no-go.
Yeah.
And so it continues to be such a struggle.
Yeah. And I would say, like, as a geriatrician, my geriatrics training did not have anything specifically focused on substance use disorders or addiction management. It wasn't until I got out and started to experience some of this stuff that I went, this is a huge community of people that we have no services for. And no one's talking about the fact that we don't have services for these. Just send them family, hoping that somebody will, like, we tell people, like, stop buying them alcohol. Like, that's going to fix the problem.
It's very challenging.
Yeah, we've definitely had some of the placement issues, particularly dialysis. We had a guy who was stable on chemotherapy, couldn't go anywhere. And one particularly vicious triangle that I think you were both describing is we have people who need some sort of placement and have multiple comorbidities, but they can't go to inpatient psychiatry because they have a substance use disorder. They can't go to inpatient substance use disorder treatment because they have a wheelchair, and they can't go to a SNF because they're on MAT. And these are, you know, it always impresses me when we're in situations like this where we're on the cusp of system change, right? How each piece can hold on to its own logic. Like, it makes sense for the SNF to say that according to the SNF. The medication costs more money, they don't get paid for that. But when you look at the system as a whole and try and connect the dots for what's the experience for this one individual, you can see where all the pieces fall apart. What do you guys out in the community want to, what does this stir up for you as we talk about these three special populations that often get missed at one point or another?
Hi, everyone. Can you hear me? Hi, this is Yamelisa. One of the bigger issues that we encounter is the Spanish-speaking population. In all three of these special populations, there's a subcategory where we fall in as monolinguals, and not having, you know, pregnant or not, for a woman, just inpatient services are not available in their language. And then for older adults, you already have the limitations of a possible disability, physical limitations, and then not speaking the language and expecting them to thrive in an environment where they really don't feel welcome. So that's one of the difficulties that we definitely encounter. I know Lehigh County does help with providing basically like a gap coverage for many of them. Usually it's supposed to be for those that are awaiting a bed, that they can begin IOP in the meantime through MARS. However, sometimes those beds just aren't going to be available. So again, those are just some of the things that we see and I've seen very often.
Yeah, thanks for bringing that up. That adds a whole nother layer, right? Any other thoughts or comments out there?
Well, this is Gail. We're always trying to differentiate, what the right placement is in terms of dual diagnosis, or, it's a tricky thing. An outpatient is even tougher. Sometimes you can't get mental health services when somebody has substance use backgrounds.
Right.
Even in our own services, unfortunately. So, so we're actually working on some of those attitudes, if you will, so that we might be more welcoming to folks for mental health treatment. I don't know how you can even say that you could separate it, but so it's, I think, a challenge to actually make ourselves more competent in mental health on substance use disorders and treat it both. Treat the whole person.
Hear, Gail. Great to hear that from you, because I know that's a struggle all around. Our patients feel it, and I know you do too.
Yeah, I know. So it is actually something we have a subcommittee working on in terms of, we're actually going to, push forward on improving our competencies in that regard so that we're more welcoming.
Great. Wonderful to hear. I'm noticing up there that we have a couple of folks that didn't get a chance to introduce themselves on the connection here. So we've got Joshua, Kevin, and Judy. If you guys want to, let's start with Josh. Just introduce yourselves and we'll move on to the case. Josh, we're going to unmute you.
Perfect.
Go ahead.
Can you hear me?
Yep.
Okay, this is Josh Rosenthal. I work with the quality department and do some work with Jillian and Kevin McNeil and some other people regarding the opioid work here within the hospital.
Great. Welcome.
Thank you.
Speaking of Kevin, you want to introduce yourself?
Yeah. Am I unmuted?
Yep.
Okay. So I'm Kevin McNeil, a family physician, work out in Hamburg. Gail, I was so excited to hear about the work that you are starting to do in that committee. That's always been a challenge for us, in family practice and primary care with patients with dual diagnosis. So I was very excited to hear that.
Yeah, thank you, Kevin.
All right, and Judy, we unmuted you.
Hi, I'm Judy. I'm a nurse care manager at 17th Street. I was previously with the GWEP program, and now I'm covering Center for Women's Medicine, the high-risk OB patients.
Great. What an interesting one for you to join here with it's all your areas of expertise. Great. Okay, let me bring up our case, and Naomi, that's you, right? Okay, do you want me to advance slides, or do you want to switch with me? Okay. I can do this, people. I can do this. Can you see from back there? Yeah. So you can sit here if you want. Yeah. Thank you. Not. Again. One more time. Where did it go? Case is.
It is for 7/9. The date just didn't.
Oh. I just noticed it too. Interesting.
Sorry, slideshow? Did I do it?
It's frozen. Not doing what it needs to do. Let's try this one more time. Anybody have any interesting topics while I retrieve this once again from my download?
A concept, so modeling after the Connections program, where the issue was we have women who are pregnant with substance use disorder who need inpatient treatment. The Connections model is to collaborate with Pyramid Hillside to say, let's get this group of folks comfortable with pregnant women in the inpatient setting. And Pyramid was very willing to do that. And so that relationship involves essentially Drs. Boyle and Flicker being basically on call for the Hillside staff. And this is sort of me summarizing as a third party, but initially there were some quite frequent calls, lots of kind of discomfort about, you know, different symptoms that the women were experiencing. If you're not comfortable treating pregnant women, low back pain, lots of different things happen that you're very nervous about. And those calls have kind of dwindled as the Hillside team got more and more comfortable.
Mm-hmm.
And so I'm just thinking, as I hear all of this, whether it's adolescents, whether it's older adults, whether it's, you know, no matter what the issue is, a pregnant woman, it's really finding ways to improve communication, even if it's through being on call, phone call, or telemedicine, to say we're here for you to kind of get things off the ground. It's the same concept as the echo, really, right? If someone's beginning to think about doing MAT in their practice and chiming in, hearing about it, talking about it, and then eventually it just becomes much more comfortable. My hope is that using forms of communication like this and through collaboration, that we get to a point where lots of different places are more comfortable with all of these populations. But I think to get past that, we all have to make ourselves available to anywhere that where our expertise is needed. You know, we all have different areas of expertise, and just find ways to kind of develop those collaborations and be available to one another.
You also have to find places that are interested in learning.
Yes.
And that, I think, is also part of the barrier, is that some places are really kind of shut down, like, this is where my line is. I don't want to go outside of my comfort area, or, you know, so I think it's great that they found somewhere that was really open to learning and partnering with them. I think that that's sometimes the tough find.
Yeah. Sometimes it takes the county or DDAP or someone to say,
you have to
together. Yeah, let's make this happen because we're going to fund it. You know. Yeah.
You're in control. Okay. That's the best I can do right now, but you can at least see it. Okay.
Hi, everybody. I'm Naomi Grube. I am a care manager for neighborhood health centers. And today's case presentation is an individual that has been with us for about a year. And it's quite concerning right now. He's a 29-year-old white male. He came to us with help with non-medication treatment. Patient is not aware of this presentation. Patient did not help with the development of any questions. Some of his strengths are the patient does care about his family. He lives with his father and his grandfather, who is very sick, his grandfather, and he adores his girlfriend. The big question that we're bringing to the group today is how to help the patient re-engage with DDAP, along with health boundaries with his girlfriend, as both are in addiction at this point. The social and support aspect of it, he began treatment with us at Neighborhood Health Centers December of 2018 for Center of Excellence with an MAT of Suboxone. He does see a licensed care social worker on a weekly basis. He has multiple recovery attempts. Patient attended IOP through NET in the past and is currently not attending at this point. Patient attended inpatient at Pyramid for 2 weeks in 2018. And the patient lives with his father, as I said before, and his grandfather, who he reports is very supportive in his addiction. Education level, he reports completing a bachelor's degree in business management. He is highly educated, and he does do a lot of reading up on addiction. Legal involvement, patient states he's never been incarcerated. He's had some run-in with the law, though, with, driving without a license and things like that, nothing really major. Employment, he's currently unemployed. He was working at Lehigh University as a dishwasher, but he was laid off currently because of school not being in session. His substance use history and labs, his current UDS's confirmation does include use of oxycodone, benzodiazepine, and alcohol. His substance use history is opiates were Percocets and oxys, marijuana, benzos, which is the Klonopin, cocaine, and alcohol. When we come down to the medical behavioral, it's the opiate use disorder. He does also have anxiety, depression, and insomnia. Medications that he has taken, again, I apologize, some of these I cannot pronounce.
No one can. It's okay. There they are. Those are meds
on the right-hand side. Yeah. Past behavioral health and community supports for relapse prevention. Reports history of previous inpatient stay at Pyramid Duncanville. It was about 2 weeks in 2018, and he checked himself out. NET for outpatient for drug and alcohol counseling briefly, and he does see a licensed counseling at neighborhood health centers for his mental health. What motivates this patient for change? Patient's girlfriend motivates him along with his father and grandfather. He's very motivated and talks a lot about his girlfriend and how he wants her to be able to be in recovery. And then patient does disclose recent use, most frequently his opiate and marijuana use. I did see the patient currently, and he had disclosed that he's also using Xanax as well now. Within the last 24 hours, oxycodone, 120 milligrams, Klonopin, 0.5 milligrams, Xanax, 2 milligrams, and he's been smoking more marijuana consistently throughout the day. Proposed diagnosis, opiate use disorder, anxiety, depression, and insomnia. Goals and treatment goals. Offering transition to Vivitrol for oral buprenorphine or naltrexone. I also do know that we had discussed a little bit about Sublocade. to encourage inpatient detox and engagement with outpatient program, healthy boundaries with his girlfriend. As of today, we also talked more about the detox portion of it. He did go for his assessment at Lehigh Valley Drug and Intake in Easton, which I think is a good thing. However, now we're getting down to we're not sure if that's what we want to do. So pretty much, peer summary, 29-year-old male.
She's going to do that for you.
Go ahead, I apologize.
So for those who are new, we have a little ritual that goes along with how we do the cases. You saw the sort of template here, and then once Naomi presents her case full of chaos, then our peer summary helps contain it a little bit.
So, and you let me know if, at the end if there's anything that you want to add. Okay. So we have a 29-year-old male with active use of oxycodone, alcohol, and increasing benzodiazepine use as of recent. He's currently on Suboxone for MAT treatment, the oral form. Although he has had previous outpatient and inpatient treatment attempts, right now he's not open to outpatient counseling or inpatient detox or inpatient stays, but he does continue to see the social worker. And right now, some treatment goals that we have for him are more encouraging those inpatient stays and more of an injectable extended release form of MAT if he still wants to continue that. And then to repeat the question that you had is how do we help him re-engage with drug and alcohol along with helping him identify some barriers in his relationship right now with his girlfriend that may not be the best right now for him.
One of the things I do want to also bring up that just kind of popped in my head, we've been, and today I actually could not, I proceeded to talk him out of driving from the facility. He was so woozy, yes, to the point where I had to have his girlfriend drive. We talked about it and all of that. He was so impaired. So I'm very comfortable with him in the setting of letting him know, like, hey, look, like, this is what's going on, this is what could happen. And it's to that point now where I think it's not just for his safety, but for safety of other individuals. Because this is now the second time this has occurred.
Okay. Include safety planning.
Yeah, safety planning as well.
Okay. All right. Well, thank you. So the next part of our ritual, dear participants, is that we open up for clarifying questions, and we'll do a round of clarifying questions from the people who are the round of people who are logged in. You get to ask questions first, and then we'll come to the table. But these clarifying questions are the questions of, what else do you want to know about this guy? What are you curious about? What came up? And then our next round of questions will be thinking about suggestions for the case. So with this first round, curiosity, not suggestion. What do you want to know so that you can make the best possible suggestion?
It's Meg. I was going to ask, does he have any internal motivating factors? The external one sounds like family and girlfriend, but is there any internal motivation?
Not at this time, no.
Okay.
This is Melissa. Is his girlfriend also a patient of the clinic?
No, she is not.
Okay. Does he have, or has he discussed with you things that he enjoys doing, not just spending time with the girlfriend, but something that, whether socially or with other people?
I've tried to discuss with him what are some of the things outside of his family and his, the girlfriend side of things. He will not he doesn't have clear answers. He's so stuck in the moment right now. I've even gone to the point of, he's got a bachelor's degree. Like, what geared you towards that, to do a bachelor's degree? And I think he just throws that to the side like it doesn't exist. Mm-hmm. So I think he just kind of, my opinion just talking with him was that it's now a waste. He can't do anything with it, which I don't believe that.
Okay, and then the other question is, Has he stated to be open to the Sublocade or any of the other injectables?
We have briefly talked about Vivitrol, me and him. The last time we had met, he was not too keen on it. He wanted to think about it. So my next step is to start talking with him about that again and Sublocade.
Okay, so Vivitrol was the one, but Sublocade hasn't been discussed yet.
Correct.
Okay.
We discussed Sublocade with him.
Did you?
Yeah.
Okay.
Over a couple of visits. At first, he said that he would think about it, he would do some research, and then when he came back, he said that he didn't need it, and that wasn't something that he was interested in anymore. So, no interest there.
Okay, and last question. Does he see his benzo use as a problem?
No.
Okay.
He doesn't see, he doesn't see that. He doesn't see how the benzos and the Suboxone are highly detrimental right now. Not at all.
I do remember he stated that he's read online that you can use, like patients have been prescribed benzodiazepines and buprenorphine at the same time, so therefore he feels that he can do that.
Yeah.
So.
Read it online, it must be true. It happens to be true, but under
It is.
it's better, yeah.
Yeah.
This is Chris. Does someone know prescribe things, or is it going to be like off the street?
Yes, yeah, they're not prescribed.
They're not prescribed. That's just the thing.
This is David. I have a couple of questions. First comment is he must have the same PCP as I do, WebMD.
There are worse ones.
Why is he in treatment? Why is he coming to you? I mean, he seems to have justified and rationalized his use. It's almost as if coming to you is his way of convincing himself it's okay.
That's quite interesting that you said that, because today when I met with him, I asked him, why are you still coming here? What's your point? And I'm very, as my team knows, I'm very blunt. I don't sugarcoat things because I'm also in recovery myself. So I understand and get it. And his question is, I'm trying. That was his answer to me. I'm trying.
Did he say what he was trying?
No, that's what his
But he didn't say why. Does he have any judicial system involvement? Is he on probation, parole?
No, the most that I know is that he's had like summary offenses, like driving offenses. No DUIs, nothing like that. Just like, speeding ticket, driving without a license because he didn't have it with him. That's it. He does, as I do know, he does have a day warrant out of another county, but it's for fines and costs. That's it.
I had to step away, but his girlfriend uses, is that correct?
Yes. I'm not 100% sure, maybe Judge, you can elaborate. I'm not 100% sure what she's actually using. I do know that she was also recently just away as well in a rehab setting. And he was more concerned about her at the last visit than himself. But I'm not sure.
I would venture to say there's some external force motivating him to come to treatment that he hasn't disclosed to you yet. And it might be some kind of judicial involvement. You can check that out online. You can do searches on people's names to see if there is.
Yeah, I already.
You already did.
I already do. I go to school for criminal justice, so that's one of the other things for my team that I do. I do a lot of PA docket searches. So that was the first thing I did this afternoon, was docket searched his name through majority of the counties in the area.
Okay. So does he see any unmanageability with his use?
No, not at all. his line of thinking was, I'm going to give myself 2 weeks before I go inpatient so I can get everything put together, meaning my bills, helping my grandfather, helping my father. He doesn't see where the unmanageability is, that you're literally talking to me and you're
Right,
falling
and
asleep.
why does he want to go inpatient again?
I think it has a factor of his father and his grandfather. I think there's something there that's kind of maybe pushing him a little bit, maybe on a living standpoint.
Okay.
And I think also from what I was hearing, the plan was for him to go inpatient to detox and at least some rehab so that he could transition to the injected naltrexone, to the Vivitrol.
At some point, yeah, that was
kind of, that's where this plan kind of emerged from, not that he wants to go to long-term inpatient treatment. Yeah. Okay.
Has he ever gone to any AA or NA meetings? And if so, what is?
In the past, he had. In the past, he has. He's done NA meetings. Currently, he has not. From what I know, probably the last 4 to 5 months, he has not gone to any meetings. And how he feels about them, I don't know. He's never given me any kind of reasoning behind that. I do know when he was going right before he was working at the university. He was going prior to that. He had stopped going because of his work schedule.
Okay. I don't have any other questions.
Okay, more clarifying questions. Any question is a good question if you're curious about anything.
Yes.
I have questions.
Okay.
Can you guys hear me?
Yeah.
Okay. So my question is, what age did the problem start? If you know that, and if we know where his mom is. I don't hear any mention of his mom.
I'm not sure where his mom is. He doesn't really talk about her. Even when we did the screening, there has been no mention of his mother over a year ago. So that's a good question to kind of throw out. Maybe that's an underlining factor. And where it started, I think it was more like a college thing. I really do. He doesn't disclose that, but it started back in college from what he has told me. When he started as associate.
Now, is that when he identifies it as being problematic use or his actual first age of use?
Problematic use. Yeah, he hasn't talked about his age use.
Okay.
He doesn't have any children, right?
No.
Okay, any other questions there? Gail and Amy and Josh, you guys are all invited too. Mary Beth, any questions?
Have we met the dad and the grandfather?
No. I actually have Thursday at 1:30 to meet with him, either at the home to get myself kind of involved in the family setting, or at a park. I kind of threw out Thursday at 1:30 to meet at the house. He's like, oh, we can, hang out on the porch. And I'm like, okay, we can do that. He's like, we can smoke cigarettes. I'm like, I don't smoke. And then he's like, well, maybe, we can also meet at the park, to make it more comfortable. So I'm pushing for the porch. But I'll take the park. But my goal with him was, and just to throw this out to the group, was my point of that was to get into the home, just to see what was the factors there. And 2, he had said to me, oh, I can stop using whenever. So my goal to him was, okay, so we're going to meet Thursday at 1:30 and let's see where you're at that point. Because he's very open and honest with me. He tells me right from the gate what he's used, when he's used it, and that I'm okay with. But that was my goal, my factor. And I think it was more so to understand where he's at, and maybe try to help him into an inpatient setting.
Do you know what the grandfather's diagnosis or prognosis is?
He told me today for 15 years he's laid in a bed, so he has no muscular use. And more than that, I don't know.
I'm just wondering, like, is he trying, like, is he terminal and he's trying to buy time? You know, like him saying, like, I need to arrange things for a few weeks. Like, is that because his grandfather's going to die in the next 2 weeks and he doesn't want to be stuck in an inpatient? Or
I don't know. I don't. Could be, but I don't think that's a factor.
Any disclosure of trauma?
No, we talked about PTSD today. He doesn't have PTSD. Nothing like that. I had done a behavioral health screening on him today. I did a lot with him today for this meeting. And no, not that I can see.
He's willing to disclose.
Yeah.
Any plan as far as for him preparing for the death of his grandfather?
No. Today was the first time that we've been meeting that he's actually talked openly about his grandfather. Like I knew he lived with his father and I knew the grandfather was in the picture, but I didn't know what was really the whole deciding factor behind that.
Mm-hmm. Okay, other questions in the room? Jillian, you got some questions?
I'm just interested, so it seems like he's amenable to inpatient on his own terms.
Mm-hmm.
Did he talk at all about his past inpatient experiences, negative, positive? There's not anything strong coming out. Because sometimes I find people have very clear feelings about their past experiences, but nothing like that would prevent him from going in.
No, not at all. He's a typical 29-year-old man who he doesn't disclose a lot of things, just keeps a lot inside. And you really got to sit down and talk, and talk on a level of, okay, where did this happen, and kind of take control of the conversation, or you're not going to get much out of him at all.
I'm really impressed at how little he's actually told us. But it seems like one of his, I like to think of it as superpowers sometimes, but one of his superpowers is not telling us very much. So that's kind of interesting. I'm curious, if there's some way for us to figure out when did he learn to get so good at that, and what has it been serving him? How's it served him so far? I think those would be interesting. He's pretty well defended, and we don't really know. We don't know why or what. We can make up lots of stories. There are plenty of plausible reasons why he might not want to disclose what really is making him tick at this moment. But we don't know, do we?
No.
Yeah,
not at all.
I'd be curious about that. Like, how and when did he learn to be so good at that?
That's something, though, as us addicts that we do. We pull up those, and we don't allow enough out. We just give you just enough.
Yeah, right.
Fly on it, and and it's okay.
Recognizing that, I'd be curious if he would tell us what that story is for him.
My curiosity is, and maybe I could be wrong, but being at that point in my life, I could maybe not, but kind of feeling secure enough to be able to talk about those things on that level, knowing that you're okay and things will be okay, but we need to kind of know where this is coming from. What's the inciting line factor of why you're choosing to do oxys and Xanaxes yesterday, and you're really not sure. You're not telling me why. I think but bottom line is,
right. So understanding what's motivating him to use it.
I have a question.
Great.
So he's seen a social worker at the health center, correct?
Yeah.
have they established much of a rapport? Like, how does he feel about going to the social worker? I'm just thinking maybe that's the opening to getting some of this information that
Me,
we don't have about him.
the social worker and I do have one-on-ones. We Skype as well throughout, and we're both very connected. He's very connected to her. He's very open with her, but just enough like he is with me and with his provider. So I think with the 3-4 individuals that maybe we could get some more information from him and that. Because me and the social worker do talk about, okay, so did he disclose this to you? That was a concern. And I would say, yes or no, or vice versa. So yeah, they do have a connection. I see it.
Okay, I have a couple more questions. As far as the procedure for NHCLV when someone is coming off your property and getting into a vehicle under the influence, what is supposed to happen? Because, for example, for us at Mars, we let them know, you get in that car, we're calling the police. Or we can call you an Uber or a taxi. So that's a big concern, the fact that it has been seen. I know that you spoke to the girlfriend and she drove, but she's also using. So maybe she wasn't as high, but that's still a little scary to have them drive, either one of them. So I don't know whether that's something that's even necessary right now to really talk about, but something to think about because it's going to continue to happen. He does not see his use as a problem. So what I guess would be plan of action if this happens again, leaving your facility, I guess, is my question. That's one.
Very good question. This is not the first time that he's done this. We actually had this in one of our huddle meetings this past Friday, and it is something that I know that our administration is looking into making a whole procedure out of it. But the first time that it had come forward to me, I was actually in Allentown, and he was in Easton at the Easton Center. What we, and Jasmine can speak to this too, was that obviously we can't take the individual's keys, but we are going to offer you an Uber. We're going to offer you a bus ticket. The individual does live in Easton, so when he was at that center that day, he could walk, and he did walk. Today, I might have went to a little bit of extreme, but I had to make sure because it kind of felt like it fell on me. I know from going to school, some of the substance or DUI tactics to do, so they don't know that you're doing them. And that's what made me say that I don't think it's a good idea for you to drive. And not everybody in the center can do those things. I'm fortunate that I know those tactics. So when I went out to speak with his girlfriend, I did speak with her about 10, 15 minutes. So with my best of my ability of what I could feel, it was either, driving the block at that point, knowing, or I would have said no, like maybe let's walk, and I would have walked with them. I would have taken that.
And we can call a taxi. What's your ER policy on that?
Yeah.
Yeah, they have to go with someone clinically sober.
Hey guys, I got to jump off. It's Gail. I just didn't want to disappear.
All right, Gail, thank you. I'll follow up with you for some questions.
Very good.
Great. Thanks for joining.
Yes, they just have to be clinically sober and under the legal limit of 80 for alcohol.
And if they're not and insist on going?
Then we take them down.
they sign out AMA.
They're right. We follow. Yeah, we can't let them go.
Mm-hmm.
ER is pretty hardcore.
Sorry, you've lost the right to AMA.
Yeah.
Enjoy your stay.
Yeah.
But in this situation, if you
I just wanted to add something to that because I had a patient. I was kind of in a similar situation where he had a alcohol issue, but had his license taken away and was still driving and showed up to the family health center. And looking out the window, and I'm seeing him get in the car, And I called the non-emergency number and reported, you know, his license plate, because he knew and he had been told numerous times that he wasn't supposed to be driving. So I felt it was my responsibility as a nurse to watch out for the greater population and report that. Because at the end of the day, he can say, well, I just left my doctor's office and they saw me driving. They didn't do anything.
Mm-hmm.
Right. So
I look at that exactly like you're taking it not just the doctor's office, but if you're at a bar, it's also the bar's responsibility and the bartender's responsibility. So I take that as that's who we are as well. If you're getting behind the wheel. So my next step, if he wouldn't have chosen to not choose any of the other deciding factors, I would have called law enforcement. Like that's what we advised the group the last time as well.
Okay. And
All right.
Just one last question. Does he have naloxone at home? Has he been given it, or does he have the prescription for it?
Yes.
Okay.
So the follow-up question for that is, do the other people in his home know how to use it?
Yeah.
Dad and grandpa.
I don't think Dad or
Right.
I'm not sure.
All sorts of opportunities for family intervention. Okay, let's switch over to suggestions. We've got probably about 10 minutes for a suggestion. How are we going to wrap our collective brains around this guy? What would you do? We'll start with you guys out there in the connected world.
I wrote down a couple different suggestions. So sitting down with him now that you have kind of broken down some of those barriers, Naomi, talking about planning and you know, thinking about what he can do in case of his grandfather's death, because he does state that he is very close to grandfather. So that's something to definitely begin discussing and planning ahead. And another thing is utilizing his intelligence. He does not see his degree as anything of a big deal. He probably flew through college, as smart as he is, and it doesn't mean anything. He probably just did it because Dad asked him to. He is happy working as a dishwasher, so that's fine. He's willing to hold any other job, but he loves to read. So my thing would be providing him with actual medical based and peer-reviewed statistics on the behaviors that he's taking, so that he reads not just WebMD or not just Google, but actual medical journals about the deaths, the toll, again, the statistics on the likelihood of, his breath being suppressed because he's taking the benzos and the bute, and kind of feeding him the information that he is willing to access. Just giving it to him that way so that he will read your information as opposed to, we can search up on Google what we want to look for, and that's what it's going to pull up instead of actual information. So that's just two suggestions there.
Really nice suggestion.
Thank you.
Build on his strengths. Thanks. As always, Yamalisa. All right, what other suggestions do we have?
I would wonder, like, maybe pushing him to figure out internally why he wants to be going to treatment and seeing guys and, utilizing the resources, because it sounds like he's been allowed to not be pushed a little bit with certain things that have seemed important, like that those motivating factors, or just even some of his history that, like someone mentioned before, that he's been around for a little while, and there's a lot that is unknown about him that could potentially impact, the conceptualization of his case and how to go about doing things. And, I also second the idea of family interventions, which sounds like you're, working on. He's not the easiest to, sort of get in with, it sounds like.
Great. So that's a great suggestion of working on uncovering and letting him speak out loud, maybe some kernels of internal motivation, help that grow. Getting the family involved. Other suggestions out there?
This is David. Do you have a formal treatment plan with him?
We did have a treatment plan with him. It's changing. It is changing.
Did he comply with the first treatment plan?
Certainly not all of it, right? Because part of that treatment plan was no benzo.
We used to, when I was doing it, we looked at the level of care, and we would change the treatment plan if the level of care changed, or of course if the client was successful and left the agency. I don't know. I wouldn't have nearly the patience you all have with this guy. He seems to be, I would think if he were my client, that he were playing me for some reason. And I don't know how much it could really help him. If he's facing all of these issues that are so dangerous and making his life unmanageable, and he's very glib about the whole process, I still don't understand what he's in treatment for. And maybe refer somebody that's like 100% drug and alcohol, to do that, and then move on to somebody who's more interested in, some kind of recovery. But, I worked with the judicial system for many, many years, and that's just my perspective. Yeah, Dave, I appreciate the perspective. I think one of the things that's interesting about this sort of primary care MAT model is that we do end up having a fair number of people that aren't actually, he's not in treatment, truly. He's coming to us for medication to prevent overdose and to help him limit his opioids. It becomes another patterns that have really helped to guide effective treatment for people who are ready. We face more ambiguity in this world that I think Jillian's also in with the emergency room, of people who are coming in and they do want something, and yet they're not really ready to claim that they're ready for recovery yet. And I think most of our cases over the last 12 sessions have been people that are in that gray area, that they want some help, but they're not ready to take that big step into recovery and the big commitment. And so we're in a different spot than some of the treatment programs, I think, Dave, and I'd love to hear more what you think about this, that when people aren't ready for treatment, we are still providing some harm reduction, and we're waiting and trying to offer some support, and waiting and offering support until the moment's right for them to go. But we don't discharge them the way a treatment program does, because we're not actually offering treatment. Right, and I respect that, and it's a very difficult position to be in, and I think a lot of it is relatively new too. With medical assisted treatment. But then there comes the issue of that you develop this relationship with a guy. And, I would look at it like, do you end up, and maybe this is the conundrum, do you end up enabling him to continue through this process? Are you helping him? Aren't you helping him? I'm not saying there's answers there, but, there's got to be a reason. There always has to be a reason that somebody does what they do. Mm-hmm. And that's what I get stuck on here, is why is he? And also, boundaries, I think, are incredibly important with a client like this. Is that you have to draw some really firm boundaries, and if he's going to continue working with him to the degree that you are, which I think is a noble investment, is that he's got to produce. He's got to give you something. He's got to help you to help him. I don't know if that makes any sense. Oh, it totally does. Yeah, and I think that's that sort of interesting set of tensions that we're working with all the time. And hopefully as a community, we build our skill set for this. How do we sort of pull in the trauma-informed care approaches? How do we set boundaries? And how do we know, if we're building relationships in a harm reduction modality, so that we aren't mandating any particular outcome, but what are we asking for in that relationship? I think that's sort of a question that's sort of that we're developing, and there are lots of people around the country who fall on either side. We have some wonderful mentors out at Mass General Hospital who say none of those questions apply anymore. People need MAT, give it to
and don't require anything else of them. This is a different tier of treatment. And they've shown great outcomes. And on the other hand, I think we, in our own program internally, don't feel like that's really what we are. That's not what we are. So where are we? How do we get clear about what is it that we think that we're doing? And I personally think that there's something important about having this place where people can rest for a little while, a little safer, and try and think about what goes next. But the suggestions that I'm hearing for this case, I think, are spot on about how do we then use that time to help this guy start to verbalize what are the relationships that matter to him, what is the external and internal motivation relationship that he's trying to struggle with, and where do we go from there? But I totally love that you brought all that up, David, because that's the struggle. That's the struggle. It's so hard and frustrating. The boundary issue is me wanting him to get it together already, you know?
Could
and
part
he's
of the
going to go
motivation.
I mean, this is Kevin. I was just, what a fascinating discussion. And really challenging. But one of the things I was just thinking of, you were saying that some people don't recommend any sort of, if people want MAT, you just give it, and I get that. But he hasn't wanted MAT.
Yeah.
He wants something. Yeah.
Yeah. So
I don't
my
think
question. I was just gonna ask my question, could it be, and as David's speaking, and I can definitely understand where he's coming from, because there's many shared feelings. Could he be so invested in continuing to come back because he's diverting or sharing with his girlfriend? Could that be because he states that she's a big motivator, she's supportive of his recovery efforts, but she's also actively using. And his goal is to keep her safe, for her to go into treatment. Like, everything is all very codependent. So could it just be that he needs his dose so that they can both stay alive, basically, and continue to manage their own use, in their own minds? He's still self-medicating, of course, and not seeing his benzo and minimizing all of that. But could it be that?
It's a good question.
Yeah. I think he knows his life's unmanageable, and I think he probably wants to do something about it, and he doesn't know how to do it. And maybe that's what he's searching for. Given his situation, you have to make the determination: is he, does he like the relationship he has with you guys? Does he like the attention? I mean, that can be part of it too. But have you talked to him about the consequences of continuing the use and how it could result in his death?
Yeah, we actually did talk today about it. When he had told me he had gotten oxycodone on the streets, then said to me, I think it was laced with something, and I said, I'm going to stop you there, and I'm going to let you know now that it probably could have been laced with something. I said, because we had a couple of issues in Bethlehem and Hellertown just recently, where oxys were cut down and rebuilt back up and had fentanyl in them.
Right.
And individuals had died from that. So I've also gone to the extreme to let him know how the benzos and the Suboxone could put him into some kind of respiratory failure at some point if it's not managed on an appropriate level. But again, an addict to an addict, when I'm talking to him, I'm understanding the barrier that I'm getting from him, because I understand that, because at one point I was there too. You can tell me whatever, but until I get to that moment, but I still put it out there to him to understand, like, this is what you're doing to your body. Even to the point where he said today, my legs hurt, I'm very stiff, and I said, well, let's break that down. Like, did you do anything strenuous? No. I said, so pretty much you're telling me that you didn't really do much, but your body feels old. You're straining. I said, you're straining your body. I said, all this stuff that you're putting into your body is very unhealthy.
Great. really interesting discussion. Some of the suggestions that I took down here was mostly about working on the relationships and and understanding the family, so that we can figure out what is it that he wants, what motivates him in his use, what motivates him in coming to us, what motivates him in dodging other treatment, and what motivates him toward recovery. All of those sorts of things that shift over time, but it'd be great to be knowing a little bit more about that and thinking about how do we manage the relationships ourselves to make sure that it's always in service to better clarity for the patient, what's going on. So people, it's the end of session 12 out of 12 for Project ECHO for our first round. I just want to celebrate for a minute. And when we're ready to close, I think we'll do a little appreciation closing before we have everybody just sign off. The news updates are that we are planning to start up again and do another round probably in September. We'll probably move to once a month over 12 months instead of twice a month. And I'll be taking suggestions for what time of day or week works for you. I will be hoping to, in either August or September, have a little gathering party and see if we can all get together and celebrate this ECHO round 1, and start making some commitments and planning for the future. But I do want to thank you all for joining us for our experiment in group collaborative learning and thinking. I think there have been a lot of things to be really excited and proud of. So for our closing, before we go and before you sign out, I would love to hear about, for you, one thing that ECHO has helped you with or contributed to in your work over the last, I guess it's been 6 months. So if you don't mind, just to keep things in order, I'm going to call out on you guys up there. And Megan, you're always first because you're up in the top corner. So Megan, one thing that you appreciate about this whole thing?
Well, today was my first day, so it was very cool and interesting to be a part of. Because I've worked primarily in just substance abuse, it was interesting to hear about it in the context of how you guys were talking about it with like sort of primary care and case management and all that stuff. It took me a little while after David was talking and giving his feedback. I was in drug and alcohol treatment. It's in its primary care context. So I guess for me that was a little bit informative, just to see how things are with that world versus how I've been doing, what I've been exposed to. Also just nice to hear everyone's thoughts on the case and the information in the beginning and all that. So thanks for having me.
Thank you. Thanks for joining us, Meg. David.
I appreciated the difference in perspective and where you're all coming from, and it's relatively new with all of the developments that have been here. I think it's a real challenge, and there's a lot to be learned from the process, and hopefully it will lead to greater rates of recovery and long-term abstinence.
Thanks, David. Love having you with us. Mary Beth.
I, as cliche as it might sound, just the connections that we make by all coming together, knowing that like we're not alone in fighting this good fight and doing this work together, is always helpful and supportive.
Thank you, Mary Beth. Judy.
Can you hear me?
Yes.
I'm on my laptop and my phone at the same time, so I'm like, I really enjoyed being a part of ECHO just because, just echoing what somebody has already said, just knowing that we're not alone and that other people are having the same concerns and issues with the patients, and how to better approach our patients being more comfortable and having those resources that they need being knowledgeable of those resources and having them available for them. Just really, it's been really exciting, and I look forward to September.
Well, thank you. Yeah, Melissa.
Hi. The last 6 months, or maybe even longer for us when we started the trial, this has been awesome. This has been absolutely amazing. I love the didactic. I love hearing from, the other side of the world when it comes to treatment. Being in the drug and alcohol field for all of these years, we really only have our perspective. So it is nice to definitely hear, the other side that our patients do encounter, but also, being able to provide our expertise and being heard, and knowing that we are doing good work, and that the doctors and nurses and nurse practitioners are seeing that our input is valuable. I think that was huge. And then, of course, the best part for me overall is just getting a true, real case and being able to pick it apart and have all of different inputs and suggestions and help an individual stay alive.
Joshua.
So, my personal experience is not with direct patient contact, and I have only been on the last 2 calls of this, just due to the point in time in which I received the invitation to join. But it's been great. It's been great to hear everybody's professional experience and their expertise, and to really take that back into my own practice and the work we do here in the quality department. I think we all have some sort of personal and professional experience with substance use disorder in some way or another these days. And, this has just been great to listen to and hear. So I do appreciate it. And thank you to everybody.
Thanks, Josh. Kevin.
Amazing, Abby. Thank you for putting this together and for educating us. I think I've mentioned this to you before, Abby. I think this is the way I think healthcare should be delivered. Just truly collaborative, getting input from several different experts from different points of view. I think about the work Lynn's done with GLEP as well. And to me, that's the way we should be approaching all of our patients with all of their problems. So thank you for this, and I'm looking forward to the next round.
Thanks, Kevin. Me too. Amy.
Thank you. I just want to thank everybody, and thank you for allowing me to be part of this. I'm looking at it from a different perspective, so I'm really looking at it and appreciating the interprofessional component of it, the collaboration, and really trying to think of how can we bring this to the medical students so they can experience really and as you said, Kevin, the collaboration, the interprofessional work for the patients and the clients, and helping each other. So Abby, maybe at some point we can talk about, what you might think would be a way to spread this to the students.
Great to hear. I might have some ideas.
Yeah.
All right, let's go around the room here. Lynn.
So I always appreciate hearing the cases and being able to bring my own case at one point in time to the group and have support in knowing, kind of that you are not facing these things alone. But I also want to thank this group for allowing me to bring my passion for older adults into it. Because it's not a topic that people really are like, ooh, geriatrics is real sexy. Talk about that group now. So thank you guys for really welcoming all walks of life.
Yeah. I thank everybody for putting this entire team together, knowing that we have communities, different counties together, and we're all kind of collaborating together on how to organize or put things together to help other individuals. And it's nice to know that we have that in the back end. And I said that the last time I was here, that it makes me feel good to be able to be a part of that. So thank you.
I appreciate everyone's willingness to share their expertise and also the opportunity to build a network of individuals that we can turn to when we really just don't know what to do or when we don't even know what questions to ask. Because even sometimes sitting at the table, we know something needs to be done, but we don't even know what question to ask. And being able to work with a group of individuals so we can be able to do that. So I appreciate that.
I appreciate that so many different people from different backgrounds and experiences are coming together to try to fight this epidemic and make a difference. You know, someone who lost someone very close to an overdose, it really means a lot. People are trying to come up with solutions to all these problems.
Jillian here. Really appreciate the whole team, Abby and the whole NHCLV team for all the hard work on this. I think it's well worth everyone's time. It feels like the biggest take home for me has been that there are lots of different ways that people recover and succeed, and lots of different ways that each of us can contribute in a collaborative way. And each of us comes from our very specific places where we do this work, and each of those places has a lot of value in them, but to hear different ways to think about doing this, from the lowest of the low barrier care all the way up to highly structured, a very rigorous substance use disorder treatment. I think there's so much value in coming to understand all the nuances to all those different approaches.
This is Chris. I appreciate the opportunity to learn as a essentially new nurse and being totally new to the whole substance abuse, opioid use disorder, drug and alcohol world. I think ECHO has given me a good example of how to collaborate with individuals, and also just to learn from everyone's expertise and seeing what little bits of each individual's expertise I can kind of incorporate into what I do on a daily basis to essentially help people. So.
Great. And this is Abby, and I deeply appreciate all of you and the gift of time that you've brought. I do deeply thank Lynn and the GWEP grant for paying us for this first round and for a chunk of the second round too. So that's one kind of appreciation is how do we make this possible at the group level. But I am also grateful to the Project ECHO team back in New Mexico that's been so open and sharing about the model, about the didactic material and mentoring that has made it so that we can come together as a community all the way from Schuylkill County through the Lehigh Valley, from people with lots of different kinds of experiences to put our heads together and make a real difference, and that's what it's all about. So look forward out there to more updates, and we will have ourselves a party sometime soon, and you're all invited. All right, thank you a million. And feel free to contact me or Star with any questions or ideas. And don't forget, if you fill out your survey, you get an extra brownie point from the survey gods. Goodbye.
Thank you.
Yes, until next time.
All right. Thanks so much, team.
Yeah.